The monitor didn't scream. It just went silent. And the line went flat. It was 1:47 a.m. in the ER at Redwood Plains Regional Medical Center, and I was already thinking about bad coffee and worse paperwork when the doors burst open. 2 military MPS rolled in a man in orange restraints, like they were late for a flight. His wrists were cuffed to the rails. His head hung to one side. Someone was doing chest compressions badly. I could tell because the rhythm was wrong. He coded 2 minutes out, one of the MPs said. Lost him on the road. Lost him. Like he was luggage. I stepped in, pushed the compressions guy aside, and checked the monitor myself. Flatline. No artifact. No pulse. The room tightened. Trauma bay lights were bright enough to show everything, including the dark foam at the corner of his mouth. It wasn't fresh blood from a wound. It was thick, mixed with secretions. That's when I stopped thinking about paperwork. Switch compressors, I said. Bag him? Bag. We moved fast. I took airway. His jaw was slack, tongue heavy. Secretions flooded the back of his throat. Not normal for a simple cardiac arrest. I suctioned. More fluid came up. It had that faint chemical smell you don't forget once you've worked outside civilian medicine. I checked his pupils. Pinpoint. That narrowed things down fast. Any trauma, I asked. No gunshot, no crash, the MP said. He just collapsed. Collapse doesn't usually come with pinpoint pupils and a mouthful of froth. I glanced at the chart clipped to the stretcher. Staff Sergeant Caleb Rourke. Military detainee transfer. Fort Harrison to Colorado. No detailed medical history attached. Of course not. We started advanced cardiac life support. Epinephrine in. Continue compressions. I placed the laryngoscope and slid the tube in clean on the first try. The secretions were heavy. I suctioned again and secured the airway. We hooked him to the vent. Still a systole, the resident said. I watched the screen. Straight line. If you've been in emergency medicine long enough, you know when a code feels mechanical and when it feels wrong. This felt wrong. I looked again at his pupils. Still constricted. Skin clammy. Heart rate before arrest reportedly slow. Excess secretions. No trauma. Prep atropine, I said. The resident blinked. For a systole. For what caused it? He hesitated just long enough for me to notice. I didn't have time for a pharmacology lecture. Trust me. Atropine pushed. We continued compressions. I asked for pralidoxime to be pulled from the crash cart supply. It's not something you use every night in Montana, but we're still a hospital, and weird things happen in rural states. One of the nurses leaned in. You thinking organophosphate? I'm thinking cholinergic crisis, I said. And I don't want to be late. Another round of meds. Compression steady now. I watched the monitor like it owed me money. Then the line twitched. It wasn't dramatic, just a ripple. Then another. Ventricular escape rhythm slow and ugly, but there. Pause compressions. We checked pulse. Weak, thready, but present. The room exhaled all at once. No cheering, no clapping. This wasn't a TV show. This was a man who had just come back from nothing and he was still hanging by a thread. If you believe doctors and nurses should tell the real stories from inside the hospital, not the polished ones, leave a comment below and tell me where you're watching from. And if you want more real ER cases like this, hit subscribe. Nights like this don't make the news, but they stay with you. We stabilized him enough to get vitals. Bradycardic. Hypotensive. Lungs wet. Vent alarms, chirping because he was fighting the tube, even half unconscious. Get toxicology on the phone, I said. And draw labs now. One of the MPs shifted near the door. Is he going to make it? I looked at him. I don't know. That's the only honest answer in an ER at 2 a.m. We transferred him toward ICU for closer monitoring, but he didn't make it past the hallway before the monitor dipped again. His heart rate slowed into the 30s. Blood pressure crashing. Back to trauma, I said. We rolled fast. He started seizing subtle at first. Just facial twitching. Then more obvious. Oxygen saturation dropped. The ventilator fought him. More atropine, I ordered. Increased dose. The resident leaned close. We don't have confirmation this is organophosphate. I met his eyes. If I'm wrong, we'll deal with it. If I'm right and we wait, he dies. We pushed another round. Within seconds, the secretions slowed. Heart rate crept up. Blood pressure stabilized just enough to keep him from sliding back into a rest. That was when he opened his eyes. Just for a second. Cloudy, disoriented, but aware enough to focus. He looked straight at me, and in a voice wrecked by a tube and oxygen, he rasped, "Still faster than the chain of command, Major." "Major." I hadn't heard that rank in over a decade. The resident glanced at me. "Major," I didn't answer him, because the past has a way of walking back into your life without knocking. I adjusted the ventilator settings to match his compliance. Checked his pupils again. Still constricted but reactive. Good sign. We started a pralidoxim infusion. Continuous monitoring, vasopressors ready if needed. The MPs exchanged a look. "You too?" I said, "How did he have access to chemicals?" One shrugged. "Maintenance detail earlier this week. Agricultural storage on base. Montana. Farms, pesticides. That tracked." He hadn't been trying to die quickly. He'd chosen something messy. Something that would give him a window. A dangerous one. His blood pressure dipped again, and for a split second the monitor threatened to flatten. My hands hovered over the crash cart. Not panicked, just ready. I've run codes in field tents with mortar fire in the background. I've pronounced people in quieter rooms than this one, but there was something about this case that tightened in my chest. Maybe it was the uniformed escorts. Maybe it was the word "Major." Or maybe it was the feeling that this wasn't just a medical emergency. It was a decision that had been made long before he rolled through my doors. His heart rate stabilized in the 60s. Oxygen climbing. Ventilator syncing better now. For the moment he was alive, but barely. And I hadn't even begun to understand why he chose to stop breathing on a highway instead of in a cell. His blood pressure dipped again, and I tightened the seal on the ventilator mask while watching the waveform fight back. The vent alarm chirped in short, irritated bursts. He was bucking the tube, not fully conscious, but not gone either. I adjusted the sedation, careful not to push too hard. Too much and his pressure would tank. Too little and he'd tear the tube out himself. Emergency medicine is mostly about threading needles no one else can see. Heart rate 58, the resident said. Pressure 86/50. Start norepinephrine at low dose, I said. Titrate slow. We had him intubated, lines placed, meds running, but the room still felt unstable. The secretions were the tell. Even with suctioning, fluid kept pooling. His lungs sounded wet, not from trauma, not from aspiration alone. This was systemic. I leaned closer and lifted an eyelid again. Pupils still constricted. Not pinpoint from opioids. Too reactive. Too symmetrical. Any chance he overdosed, the nurse asked quietly. Not like this, I said. Organophosphates block acetylcholinesterase. That means acetylcholine floods the synapses. Muscles contract when they shouldn't. Lungs fill when they shouldn't. The body basically short-circuits itself. I'd seen it overseas when local farmers stored chemicals next to food. It's not dramatic. It's slow and ugly. Get me a red blood cell cholinesterase level, I said. And send a stat tox panel. The resident frowned. That'll take hours. I know. One of the MPs shifted near the door again. Doctor, we weren't told anything about poison. That doesn't surprise me, I said without looking at him. His fingers were flexing against the restraints. Even sedated small fasciculations moved across his forearm. Another clue. Increase atropine, I said. We're not dry yet. We pushed more. Within a minute, his heart rate climbed into the 70s. Secretions eased just enough that suctioning wasn't constant. Oxygen saturation stabilized at 94% on the vent. For about 30 seconds, it looked like we were ahead. Then the monitor stuttered. Not a flatline. Worse. Wide, complex rhythm. Unstable. Arrhythmia, the resident said. I see it. Blood pressure dropped again. The norepinephrine was already running. I adjusted the dose myself. The nurse met my eyes. No one in that room thought this was routine anymore. He coded once on the road, one MP said. You're saying this wasn't just random. I'm saying. I replied that bodies don't behave randomly. We shocked once to correct the rhythm. It converted back to sinus, but barely. His lactate from the first blood draw came back elevated. Hypoxia had already done damage. Was he complaining of anything before he collapsed? I asked the MPs. One hesitated. He said he felt nauseous, sweating, asked for water. Classic. And you didn't think to mention that when he arrived. We thought it was anxiety. I didn't answer. People assume anxiety covers a lot of things. It doesn't cover this. His oxygen saturation dipped again as fluid shifted in his lungs. I adjusted PEEP on the ventilator. The resident looked uneasy. If this is organophosphate, shouldn't we be seeing more bradycardia? He asked. We did, I said. You just didn't see him before he arrested. He didn't push back after that. Another round of labs went out. I asked for a chest X-ray portable. Not because I expected trauma, because I needed a baseline. We had to document everything. When a military detainee codes in your ER paperwork matters almost as much as airway. The X-ray came back showing diffuse infiltrates, consistent with aspiration and pulmonary edema. That tracked with what we were seeing. No bullet holes, no fractures, no internal bleeding, the nurse said, glancing at the hallway. There's a colonel asking for you. Of course there was. Tell him he can wait, I said. She nodded and went back to titrating drips. I leaned in close to check tube placement again, listening for equal breath sounds. The man on the table wasn't a symbol. He wasn't a case file. He was a patient in respiratory failure with unstable cardiac rhythm and a body flooded by a toxin he chose to swallow. Chose. That thought settled in slowly. People who want to die don't usually pick slow methods with unpredictable outcomes. They pick certainty. This wasn't certainty. This was timing. His fingers twitched again. Not random. Purposeful enough to notice. I lowered sedation slightly to assess neurologic response. His eyes fluttered under the lids. He wasn't brain dead. That mattered. Doctor, the resident said carefully, if he deteriorates again, at what point do we consider that we're prolonging something inevitable? I looked at the monitor, then at the man's chest rising under mechanical breaths. I consider inevitability after we've exhausted options, I said. Another lab result pinged in. Electrolytes within range. No massive metabolic derangement beyond what hypoxia would explain. No obvious co-ingestions yet on preliminary tox screen. But organophosphate levels wouldn't show up instantly. His heart rate climbed again, now too fast. We adjusted. Every few minutes it was something new. That's the thing about toxic exposures. They don't follow clean scripts. One of the MPs cleared his throat. He's being transferred under federal order. We were told no delays. I met his eyes for the first time. He's not stable. That's not a delay. That's medicine. He didn't argue. He just looked uncomfortable. The colonel walked in before anyone could stop him. Mid-50s, pressed uniform, the kind of posture that doesn't bend easily. Doctor, he said evenly, I didn't step away from the bed. He's unstable. He glanced at the monitor, then at the vent settings, like he understood more than most visitors would. What did he take, he asked. Organophosphate, I said. His jaw tightened slightly. That was confirmation without words. So he knew. He shouldn't have had access, the colonel said. And yet he did. The monitor beeped steady for now. Not strong, just steady. The colonel looked at me, again really looked at me like he was placing a face with a file. You're Mercer, he said. Not doctor. Mercer. My hands didn't stop moving as I adjusted the infusion pump. Yes, I said. He nodded once slow. I was told you were out. Out. That word meant different things in different rooms. Another dip in blood pressure pulled all our attention back to the monitor. I increased the pressure again. The resident was already preparing backup medications. The colonel stepped aside, but he didn't leave. Neither did I, because the man on that table wasn't finished fighting yet, and neither was I. The colonel didn't raise his voice, but the way he said my name made the room smaller. "You're Mercer," he repeated like he was confirming a detail from memory instead of asking a question. I kept my eyes on the monitor. He's still unstable. I can see that. Caleb's blood pressure held in the low 90s systolic, with pressor support. Heart rate in the high 80s now. Ventilator finally syncing better. The atropine had dried up most of the secretions. For the first time since he rolled in, the alarms weren't competing with each other. The colonel stepped closer to the foot of the bed, careful not to interfere with lines or tubing. He studied the chart screen, then glanced at me again. "You were Army Medical," he said. "Not a question. Yes." "Forward surgical team." "Yes." The resident looked between us like he'd just walked into a conversation he didn't know existed. The nurse kept adjusting drips like none of this was unusual. "Good nurse." Caleb's eyelids flickered again. Sedation was light but controlled. I didn't want him fully awake yet. His body didn't have the margin for agitation. The colonel lowered his voice. "How did you recognize it?" "Experience," I said. He held my gaze a second longer than necessary. That was enough. Behind him, one of the MPs shifted his weight. They weren't used to being outside the chain of command. Civilian hospitals don't respond to rank. We respond to vitals. Caleb's fingers moved again against the restraints. More purposeful this time. I leaned in slightly. "Caleb," I said firmly, "you're intubated. Don't fight it." His eyes opened halfway, focused, locked onto mine. "You always were," he rasped around the tube, barely audible. "Faster." The resident froze. The nurse paused mid-adjustment. Caleb's eyes didn't leave mine. Then the chain of command. There it was again. "Major." The colonel inhaled slowly. "Sedation up slightly," I said to the nurse, keeping my voice even. We adjusted. Caleb's eyelids drooped but didn't fully close. The colonel waited until the immediate tension eased. "You two served together?" he asked. "No," I said. "Yes," Caleb whispered at the same time. I ignored him and checked his central line placement. Good flow. No infiltration. "We were in the same theater," Caleb continued, voice thin but deliberate. "Different ends of the mess." The colonel's jaw tightened. He didn't like that word. The resident finally spoke. What mess? I didn't answer him. This wasn't his history. Caleb's blood pressure dipped again. Not dramatic, but enough to pull my attention back to numbers instead of memories. I adjusted the pressor infusion up by a fraction. The colonel watched the monitor like he understood what those numbers meant. That told me he'd spent time around medical units. Helmand, Caleb said softly. That word landed heavier than it should have. Helmand Province, 2011. Heat dust and paperwork that didn't match what I'd seen with my own eyes. Save your strength, I said. He gave a faint, humorless smile. That's why I'm here. I checked his pupils again. Slightly less constricted now. Good. The pralidoxime was doing its job. The colonel stepped closer to me, just out of earshot of the others. You shouldn't be involved in this, he said quietly. I'm already involved, I replied. He's my patient. He's a detainee under federal transport, and he's intubated on a ventilator in my ER. That ended that. Caleb shifted again, more alert than I liked. Sedation was tricky in toxic cases. Too much, and you suppress respiratory drive beyond recovery. Too little, and stress pushes them back into arrhythmia. Why, I asked him directly. The colonel glanced at me sharply. Doctor, I'm asking my patient a question. Caleb's eyes held mine. Even weak, there was calculation there. They were moving me, he said. Colorado. I know. Deposition, he whispered. The resident's head snapped up. Deposition. The colonel didn't look surprised. He looked tired. Caleb's heart rate crept upward with the effort of speaking. I adjusted sedation slightly but let him stay conscious enough to respond. You tried to kill yourself, I said flatly. He gave the smallest shake of his head. No. The monitor beeped steady, almost calm. Then explain the pesticide in your bloodstream, I said. His lips twitched around the tube. Timing. That word settled into place slowly. You swallowed it before transport, I said. He blinked once. You gambled on the nearest civilian hospital, I continued. Another blink. And you hoped I finished that I'd be here. He didn't deny it. The colonel exhaled through his nose. This was not part of any authorized— I know, Caleb interrupted weakly. The nurse shot him a look. You need to stop talking. He ignored her. If I died on the road, he said, eyes still on me, the file dies. The resident swallowed. What file? I kept my voice steady. The kind that gets sealed. The colonel stepped back slightly like he was recalculating the situation in real time. Dr. Mercer, he said carefully, using the full title. Now you need to focus on stabilization. Legal matters are not your concern. They are if they affect patient care, I replied. Caleb's blood pressure wavered again, dipping into the 80s systolic. I increased the pressor a notch and checked capillary refill. Slow but present. He wasn't trying to die. That much was clear now. He had picked a toxin that gave him a window. Dangerous, yes, but survivable with rapid intervention. He had needed a delay. You couldn't trust the transport, I said quietly. His eyes sharpened. Not about dying, he whispered. About disappearing. The room went still in a different way this time. The colonel's expression didn't change, but his posture did. Less command, more caution. Your deposition is scheduled, the colonel said evenly. You will reach it. Caleb gave a faint skeptical look. If he crashes again, I said he's not going anywhere. The colonel met my eyes. You'll clear him when he's stable. I'll clear him when he's safe, I corrected. Another arrhythmia flickered across the screen, brief and self-limiting. Enough to remind everyone how fragile this still was. The resident stepped closer to me. You knew about this deposition. No, I said. But I know what it looks like when someone decides not to vanish quietly. Caleb's breathing synchronized better with the ventilator. Oxygen held at 96% now. Heart rate in the 90s. Blood pressure barely stable with support. Not good. Not terrible. Just balanced on a wire. The colonel's eyes lingered on me again. I was told you were out, he repeated softly. I am, I said. He nodded, but he didn't look convinced. Neither was I. I adjusted the pralidoxim drip and watched the infusion pump tick forward, like it was buying him minutes. The colonel stepped aside to take a call, voice low and controlled. Caleb lay restrained, sedated just enough to keep him from pulling lines, but alert enough to know where he was. His blood pressure hovered in the low 90s with pressor support. Oxygen stable. Heart rhythm narrow and regular for now. Labs are coming back, the resident said, glancing at the screen. Preliminary tox panel, negative for opioids. Benzos common agents. Organophosphates won't show up on a basic panel, I said. A few seconds later, another result populated. Red blood cell cholinesterase level significantly depressed. There it was. Confirmed, I said quietly. The resident let out a slow breath. So he really did ingest pesticide? Yes. The colonel ended his call and stepped back in. What's the status? Organophosphate poisoning? I said. Severe enough to cause respiratory failure and cardiac arrest from hypoxia. He swallowed it intentionally. The colonel's expression tightened. Not shock. Recognition. That compound shouldn't have been accessible, he said. But it was, I replied. One of the MPs shifted uncomfortably. There was a maintenance detail earlier this week. Storage shed for agricultural supplies on base. We inventory those chemicals, but you're short-staffed, I finished for him. And you don't expect a detainee to plan chemistry experiments. The MP didn't respond. Caleb's fingers flexed again. His sedation level was holding, but he was still listening. You picked something slow, I said to him. Not instant, not guaranteed. He blinked once. You needed time, I continued. His heart rate ticked up a few beats. Not enough to destabilize him, just enough to register that I was right. The colonel crossed his arms. He will answer questions when appropriate. He's answering now, I said. Caleb's voice came thin and hoarse through the tube. Window. You wanted a window, I said. Another blink. To delay transport, I added. Yes. The resident shook his head slightly. That's reckless. You could have died. Caleb's gaze shifted toward him. Even weak, there was something steady there. Better odds, he whispered, than the alternative. The colonel stiffened at that. I checked his arterial line waveform. Clean tracing. Blood gases pending. I didn't look at the colonel when I spoke next. He believed the transport wasn't in his interest. The colonel's voice was flat. Transport was authorized. Authorized doesn't mean safe, Caleb rasped. The room fell quiet again. I wasn't interested in adjudicating military logistics. I was interested in physiology. His lactate was trending down slightly with improved perfusion. Good sign. We'd gotten oxygen to tissues in time. Any idea exactly what formulation he took? I asked the MP. Concentrated agricultural pesticide, he said. Used for crop storage, Montana farms, grain silos, rodent and insect control. Likely high potency, I said. Extended release if he ingested enough concentrate. The resident frowned. Extended release. Some agricultural compounds bind to fats and release over time, I explained. He may look stable and crash again hours later. The colonel absorbed that without reaction. How long until he's transportable? I didn't hesitate. Not tonight. He held my gaze. There are federal timelines involved. There are also ventilators and pressors involved, I replied. He leaves this hospital unstable, and he codes again on the road that's on me. The colonel didn't argue with that. He understood liability, even if he didn't like the constraints. Caleb's blood pressure dipped slightly as sedation deepened. I adjusted down a fraction. His pupils were less constricted now, another sign the antidote was working. Why this hospital? I asked him. His lips moved against the tube. I leaned closer. Closest, he said. En route, not because of me. A faint, almost amused look passed across his face. You're here, he whispered. That wasn't guaranteed. Nothing is. That much was true. The resident stepped closer to me. If he'd collapsed 10 minutes earlier, he would have coded on base. And they might not have had pralidoxime ready, I said. And 10 minutes later he pressed. Then he might have arrested in a smaller facility without full ICU capacity. The resident nodded slowly. So this was a gamble. Yes, I said. A bad one. Caleb's eyes shifted to the colonel. They were moving me, he said, voice barely audible. I know, the colonel replied. Colorado, Caleb added. The colonel didn't confirm or deny. Deposition scheduled, I asked quietly. The colonel looked at me carefully. That information is restricted. Is it accurate? I pressed. A pause. Yes. There it was. Caleb's heart rate climbed again slightly, not from instability, but from effort. If I didn't make it, he said, file closes. The resident glanced at me, confusion written clearly across his face. What file? Federal review, the colonel said evenly. Nothing that concerns medical operations. Caleb's eyes flicked back to me. Helmand, he said. The name hung between us. I felt something shift in my chest, not dramatic, just old. Focus on breathing, I told him. I am, he said. The irony wasn't lost on me. The nurse leaned over the monitor. Pressures holding, oxygen steady. For the first time since he'd rolled in the room, felt temporarily balanced. Not safe, just balanced. I looked at Caleb again. You didn't want to die, I said. He shook his head slowly. You wanted to delay. Yes. You believed someone might make sure you didn't reach that deposition. He held my gaze without blinking. The colonel spoke, voice measured. There is no evidence of that. There's also no guarantee of the opposite, Caleb countered weakly. I adjusted the ventilator rate down slightly as his spontaneous breaths increased. You understand, I said to him, that if this had gone wrong, you'd be dead. He gave the faintest shrug he could manage under restraints and tubing. Better than disappearing, he said. The colonel's jaw tightened again, but he didn't interrupt. I checked the infusion rates one more time and reviewed the lab trends. He was still critical, still unstable, still alive. And now it was clear this wasn't a suicide attempt. It was leverage. I just wasn't sure yet who he thought he was leveraging. I signed the ICU admission orders and wrote in clear language, "Patient unstable for transport due to ongoing cholinergic crisis and vasopressor dependence." The words mattered. In a case like this, every word mattered. Caleb was moved upstairs under full monitoring. Ventilator portable. Drips secured. 2 nurses and a respiratory therapist at his side. The MPS followed close behind, eyes scanning hallways like they expected resistance from vending machines. By the time we reached ICU hospital, administration had already been notified. Word travels fast when a military detainee codes in a civilian ER. I stayed at the bedside as the ICU team connected him to their monitors, pressures holding with support, heart rate steady in the 80s. Oxygen saturation stable on mechanical ventilation. Not good. Not crashing. Balanced on chemistry. His red blood cell cholinesterase is significantly depressed, I told the ICU attending. Confirmed organophosphate ingestion. We're running pralidoxime continuous infusion and titrating atropine as needed. The ICU attending nodded. He's stable enough for transfer out of facility. No, I said immediately. Before that conversation could go further, the unit doors opened again. Mr. Ethan Crowley walked in wearing a dark suit that looked out of place against hospital scrubs and isolation carts. He wasn't military. No uniform. No visible badge. Just calm posture and a folder under his arm. "Doctor Mercer," he asked. "Yes." He offered a professional nod. "Ethan Crowley, Office of Interagency Compliance." "That sounds official," I said. "It is." He glanced at Caleb's chart on the screen without touching anything. "I understand there were complications during transport. He experienced cardiac arrest secondary to toxic ingestion," I said. "He is currently unstable." Crowley's expression didn't change. "We have a federal deposition scheduled within 72 hours. I'm not his calendar," I replied. "I'm his physician." He shifted his weight slightly, adjusting the folder in his hand. "We need to know when he can travel safely. You need to know when he won't die in an ambulance," I said. Behind him, the colonel entered quietly. He didn't look surprised to see Crowley. The ICU nurse glanced between us and kept charting. Professionals know when to stay out of jurisdictional tension. Crowley lowered his voice. "Staff Sergeant Rourke is a material witness in an ongoing sealed federal matter." "I'm aware," I said. "His testimony is time-sensitive. So is his oxygen saturation," I answered. He didn't smile. He wasn't there for humor. "Doctor," he continued, "federal custody transfer was authorized prior to this incident. Delays impact multiple agencies." I folded my arms. Under EMTALA standards, a patient cannot be transferred unless stabilized. He is not stabilized. Crowley studied me. Define stabilized. Stable vital signs without pressor support. No active arrhythmia risk. Adequate respiratory function without mechanical ventilation. He glanced at the ventilator, then at the norepinephrine drip. "And your estimate?" "I don't give estimates in toxicology," I said. I watched trends. Caleb stirred slightly at the sound of voices. His eyelids opened halfway. Crowley noticed. "You're awake," he said evenly. Caleb looked at him without responding. "Your cooperation is appreciated," Crowley added. Caleb's lips moved around the tube. I leaned closer. "Don't speak. Save your energy." Crowley looked at me again. "Did he indicate why he ingested the compound?" "He indicated he wanted a delay," I said. "Delay from what?" Crowley asked. "You already know," I replied. The colonel cleared his throat. "This is not the setting for operational discussion." Crowley nodded slightly. "Agreed." He turned back to me. "Dr. Mercer, we are not asking you to compromise care. We are asking for clarity on timeline. You'll get clarity when his blood pressure holds without artificial support," I said. Crowley considered that. "You understand the implications if he deteriorates further." Yes, I said. And if he improves rapidly, then I'll reassess. Crowley opened his folder and removed a single sheet. This confirms deposition scheduling and material witness status. I didn't take it. I don't need paperwork to treat a patient, I said. You may need it for hospital administration, he replied. Right on cue, my phone buzzed. Chief Medical Officer. I stepped a few feet away but stayed within sight of the monitors. Angela, the CMO, said, voice tight. I'm being told federal custody is requesting transfer clearance. He's unstable, I said. Document thoroughly, he replied. Legal is involved. I already did. Good, he paused. This is going to be reviewed. I expect it to be. I ended the call and walked back to the bedside. Crowley was still there. So was the colonel, hospital administration, Crowley asked. Yes. And their position, that I document everything and practice medicine? Crowley nodded once. Fair. Caleb's blood pressure dipped slightly again. Not catastrophic, just a reminder that chemistry doesn't care about federal schedules. I adjusted the pressor infusion by a small increment. Crowley watched closely. You're very certain, he said quietly. I'm cautious. I corrected. He shifted his focus to Caleb. You created this delay intentionally. Caleb's eyes narrowed slightly. Even sedated, he wasn't confused. Yes, he managed. Crowley didn't react. Why? Caleb's gaze moved briefly to me, then back to Crowley. Control, he whispered. Crowley absorbed that without visible emotion. The colonel spoke. The transport was secure. Secure, Caleb repeated faintly. Sure. His heart rate climbed a few beats. I increased sedation slightly to blunt the stress response. Don't engage, I said firmly. Not now. Crowley stepped back half a pace. Dr. Mercer, he said, if he remains ventilator-dependent at 48 hours, alternative arrangements may be necessary. That's not your call, I replied. It becomes my call if federal custody cannot proceed, he said calmly. I met his eyes. It becomes your problem, not your call. There was no anger in my voice, just fact. He studied me for a long second. You served, he said. Yes. Then you understand chain of command. I understand medical autonomy, I said. The ventilator hissed rhythmically. The monitors beeped steady, almost deceptively calm. Crowley closed his folder. We will reassess in 12 hours, he said. I reassess every 5 minutes, I replied. He nodded once and stepped toward the door. The colonel followed, pausing briefly. He needs to reach that deposition, the colonel said quietly. He needs to survive tonight, I answered. They left without another word. I looked back at Caleb. He was watching me again, eyes clearer now despite sedation. You bought time, I said. His gaze didn't waver. I'm deciding how much I added. The monitor continued its steady rhythm, each beat measured and temporary, like a clock counting something neither of us could afford to ignore. I lowered the ventilator rate slightly as his spontaneous breaths began to trigger the machine on their own. It was a small improvement, but enough to tell me the antidote was working. His oxygen saturation held at 97%. Blood pressure still supported but steadier. The ICU nurse adjusted the sedation pump with quiet efficiency. Caleb's eyes opened again. Don't talk, I said automatically. He ignored that. Helmand, he repeated, voice thin through the tube. The words settled into the room like it had weight. The ICU attending glanced at me. You two have history. Same deployment, I said. Different units. That was the simplified version. Helmand Province 2011. Forward surgical team. Dust that never left your boots. Heat that made metal burn skin. We handled trauma triage, anything that rolled in breathing or not. One afternoon, a detainee was transferred to our care. Young, dehydrated, agitated, respiratory rate climbing before anyone officially noticed. I documented tachypnea, altered mental status, declining oxygen saturation. He wasn't stable for transport. That was my assessment. Hours later, I was told the detainee had been moved anyway. The next morning, I learned he had coded during transfer. Official record later stated, "Stable at time of handoff." Those were not my words. Caleb had been transport NCO on that movement. He had stood outside my tent that afternoon while I argued with someone 2 ranks above me that the detainee needed more time. I lost that argument. The ICU monitor beeped steadily, dragging me back to the present. "You filed an incident report," Caleb said faintly. "Yes." "They edited it." "Yes." The ICU attending looked between us, clearly trying to decide whether to ask questions or pretend none of this was happening. Crowley's words echoed in my head. "Sealed deposition. Material witness." "You're testifying about that transfer," I said. Caleb's eyes didn't blink. "And more," he whispered. The pressor pump clicked as it adjusted flow. "Why now?" I asked. He inhaled shallowly against the ventilator support. "Internal review reopened," he said. "Someone pulled archived medical logs. That meant electronic records. That meant someone compared original entries to final reports." "You're the one who confirmed the timing," I said. "Yes. And that puts you in conflict with someone higher." "Yes." The ICU attending stepped closer. "Doctor, is this relevant to his care?" "Yes," I said without hesitation. How he pressed. "Stress response destabilizes toxic patients. If he escalates emotionally, he crashes physiologically." That was true. It just wasn't the whole truth. Caleb shifted slightly against restraints. "You didn't back down," he said to me. I adjusted the sedation a notch higher. "You should conserve oxygen," I said. "You filed anyway," he continued. "I documented what I saw. And they told you to rewrite." I didn't answer. The ICU attending looked at me carefully now. Not curious. Assessing. Caleb's heart rate crept upward with the effort of speaking. "They told you to say stable," he said. "They told me to align language," I replied evenly. He gave a weak huff that might have been a laugh. "And you left," he said. "I completed my contract," I corrected. But he wasn't wrong. I didn't leave because of one transfer. I left because I understood how quickly documentation could bend under pressure. Caleb's blood pressure dipped slightly as sedation deepened. I adjusted down a fraction. "You're testifying that the detainee was unstable before transport," I said. "Yes." And that command knew. "Yes." The ICU attending took a slow breath. "That's significant." "It is," I said. Caleb's gaze locked onto mine again. "If I didn't make it to deposition," he said, "record stays clean." "Clean for who?" I asked. He didn't need to answer. The ventilator alarm chirped briefly as he attempted a stronger, spontaneous breath. I adjusted sensitivity settings. "You understand," I said quietly, "that ingesting organophosphate could have killed you before you ever reached this hospital." "Yes." "Why trust the timing?" He blinked slowly. "Route predictable," he said. "Hospital capacity known." "You researched our facility," I said. "Yes." "You knew we stocked pralidoxime." "Yes." "You didn't know I was on shift." "No." That was the honest part. "So this wasn't about me specifically," I said. "It was about odds," he replied. The ICU attending leaned against the counter. He bet on hospital capability. He bet on rural preparedness, I said. And he'd been right. The colonel reappeared at the doorway, silent but attentive. "You've discussed enough," he said calmly. Caleb's eyes flicked toward him. "Helmand wasn't clean," Caleb said. "It was reviewed," the colonel replied. "Reviewed by who?" Caleb whispered. The colonel didn't respond. I checked arterial blood gas results as they populated on the screen. pH improving. Oxygenation acceptable on current settings. Carbon dioxide within tolerable range. He was trending in the right direction. For now. "You swallowed pesticide to control where you landed," I said to Caleb. "Yes." "You wanted a civilian medical record documenting everything." "Yes." "And you needed to survive long enough for that record to exist." His gaze stayed steady. "Medical records don't disappear easily," he said. He was right about that too. The ICU attending spoke carefully. "Dr. Mercer, are you comfortable continuing as primary on this case?" "Yes." He studied me another second. All right. Caleb's eyelids drooped slightly as sedation took stronger hold. You were right back then, he said quietly. About what? I asked. He wasn't stable. The monitor kept its steady rhythm indifferent to memory. I know, I said. The colonel shifted his weight at the doorway. This hospital is not a tribunal, he said evenly. No, I replied. It's a record. Caleb's breathing synchronized with the ventilator again smoother now. He didn't say anything else. He didn't need to. The numbers on the screen told me what mattered most in that moment. He was still alive, and the physiology was finally starting to cooperate with the story he dragged back into the light. I watched the arterial line waveform flatten for half a second before the alarm caught up. Pressure's dropping, the ICU nurse said. I was already at the pump, increasing the norepinephrine by small increments instead of one reckless jump. His systolic slid from 94 to 82. Heart rate climbed into the 100s. Not from emotion, from physiology. Check potassium again, I said, and repeat lactate. The ventilator began to alarm for high peak pressures. His lungs were stiffening. Secretions increasing, respiratory therapy called out. I leaned in and suctioned through the tube. Thick, frothy fluid again. Less than before, but enough to remind us the toxin was still circulating. Organophosphates can redistribute, I said. This isn't a straight line. His oxygen saturation dipped to 88%. Increase FiO2 to 100%, I ordered. The monitor responded, slowly climbing back into the low 90s. Crowley was back within minutes, like someone had texted him when the numbers shifted. Status, he asked calmly. Unstable, I said without looking at him. The colonel stood beside him, this time silent. Caleb's body jerked suddenly. Not a full seizure, but more than a twitch. Possible seizure activity, the nurse said. Draw up benzodiazepine, I said. Low dose. We pushed it carefully. His movements eased, but the sedation tipped him closer to hypotension. Pressure 78 systolic. More pressure, the resident said. I know, I replied. I adjusted the infusion again. His skin was pale now, capillary refill slow. This was the part toxicology textbooks gloss over. They describe mechanisms. They don't describe the weighting. A BG back, the nurse said. pH dropping. CO2 rising. He's tiring, I said. Adjust vent rate up slightly. The respiratory therapist complied. Crowley stepped closer, careful not to cross into anyone's workspace. If he requires prolonged ventilator support, he said, Federal Medical Transport can provide critical care capability. That's not the point, I replied. The point, he said evenly, is that he needs to reach deposition intact. The point, I said, is that he doesn't reach anything if he codes again on a helicopter. Caleb's heart rhythm flickered. PVCs, then a brief run of ventricular tachycardia. Get ready, I said. The rhythm converted on its own after a few beats, but it was a warning shot. You're losing him, Crowley said quietly. No, I said. He's fighting chemistry. The colonel finally spoke. Dr. Mercer, what are the odds? I don't give odds, I answered. I give treatment. Another drop in pressure. This one's sharper. 68 systolic, the nurse said. I increased the pressor again, then added a second agent at low dose. Multipressors meant we were past comfortable territory. Caleb's eyelids fluttered despite sedation. His fingers tightened against restraints. Stay with me, I said firmly. His eyes opened just enough to focus. Not done, he whispered. Good, I said. The monitor flattened for 2 full seconds. No waveform, no rhythm. Pulse check, I ordered. Nothing. Start compressions. The ICU nurse was already in position. I watched the clock. 1 minute, 2. We administered epinephrine, continued compressions, ventilated. This wasn't the dramatic chaos people imagine. It was controlled urgency. Everyone in the room knew their role. Rhythm check, I said. A faint line trembled across the screen. Then a narrow, complex rhythm returned. We've got something, the resident said. Pulse, weak, but there. We stopped compressions. Caleb's chest rose under the ventilator. The monitors re-established their steady, fragile pattern. Crowley didn't move. He didn't flinch. He just watched. "That's 2 arrests," he said quietly. "Yes," I said. "And you're still declining transfer?" "Yes." The colonel's gaze sharpened. "Dr. Mercer, I will not move him in this condition." Silence settled thick and clinical. Caleb's blood pressure crept back into the low 80s with aggressive support. Oxygen stabilized in the low 90s. "He's not stable enough for a gurney ride across this building, let alone across state lines," I said. Crowley studied the monitor, then me. "If he deteriorates further, he said there will be questions." "There are already questions," I replied. The ICU attending stepped closer. "She's correct. Transfer now would be high risk." Crowley nodded slightly, acknowledging the second voice. Caleb stirred again, weaker this time. "You still here?" he whispered. "Yes," I said. "Good." His heart rate climbed again with the effort of speaking. "Stop talking," I ordered. He ignored me. "They'll say I was stable," he said. "No," I replied evenly. "Not this time." The colonel's jaw tightened at that. Caleb's eyelids closed halfway as sedation deepened. The monitors continued their steady rhythm, each beat more fragile than the last. Crowley turned slightly toward the colonel. "If he cannot maintain hemodynamic stability within the next 12 hours, we may need contingency planning." "What kind?" I asked. "Federal critical care air transport," he said. "With armed custody." "He won't survive that tonight," I said. "That remains to be seen." I stepped closer to the bed. "You don't get to experiment with him," I said. Crowley's expression didn't change. "We're not experimenting. We're managing federal risk." "I'm managing a human being," I replied. The room fell quiet again. Caleb's oxygen saturation dipped to 89%, then climbed slowly back to 92 as the ventilator compensated. "Trend is improving post-arrest," the resident said carefully. "For now." I reviewed his labs again. Lactate still elevated but not climbing. Electrolytes within acceptable limits. No new arrhythmias in the last 5 minutes. It was the closest thing to stability we'd had all night. Crowley closed his folder. "We will reassess at dawn," he said. "I reassess every 5 minutes," I repeated. He gave a brief nod. The colonel lingered a moment longer. "He needs to make it," he said quietly. "He needs to stay alive," I answered. They left the unit without another word. I looked down at Caleb. His breathing was synchronized again. Pressors still running, monitors still steady. He had gambled on timing. Now the clock wasn't his. It was mine. I adjusted the ventilator settings again, watching his oxygen saturation hover in the low 90s, like it couldn't decide where it wanted to land. The ICU lights were dimmed to night mode, but nothing about the room felt calm. Caleb was still on 2 pressors. Heart rate just under 100. Blood pressure barely holding in the high 80s systolic. The kind of numbers that look acceptable on paper and terrible in real life. The nurse checked his pupils. "More reactive than earlier," she said. "That's good," I replied. But good was relative. Caleb's eyelids fluttered open again, not fully alert, but not lost either. Sedation kept him from thrashing, but he was aware enough to follow voices. "You still here?" he whispered faintly. "Yes," I said. "Good. Don't waste oxygen talking." He gave the slightest nod. The ICU attending stepped closer. "If he codes again, we need to have a realistic conversation." I didn't look at him. "We're not there." "We might be." He wasn't wrong. Caleb's heart rhythm flickered briefly. Another run of ventricular ectopy. Not sustained. Just enough to make the monitor chirp. The nurse's hand hovered over the crash cart. "Electrolytes stable?" I asked. "Yes," she said. "Potassium normal. Magnesium normal." "Then this is toxin-driven," I said. Crowley reappeared at the doorway, quiet as before. The colonel wasn't with him this time. "Update," he asked. "Still unstable?" I said. He stepped inside, but kept distance from the bed. "If he deteriorates beyond recoverable thresholds," Crowley said carefully, "federal custody protocol requires notification." "Define recoverable," I said. "Neurologic compromise incompatible with meaningful recovery. He's responsive," I said. "He follows commands." For now, Crowley replied. Caleb shifted slightly at the sound of his voice. You think I'm fading? Caleb whispered. Don't engage, I told him. Crowley's expression didn't change. You made a dangerous calculation. I made a necessary one, Caleb said. His blood pressure dipped to 75 systolic. Press her up, I ordered. The nurse adjusted the infusion. Caleb's eyes drifted toward me. If I die, he said, voice barely audible, they close it. I leaned closer. You're not dying. You can't promise that. No, I said. But I can treat you. His breathing became uneven against the ventilator. I adjusted the sedation slightly enough to blunt the stress, but not enough to drop his pressure further. The ICU attending folded his arms. Angela, if he arrests again, we need to clarify code status. He's full code, I said. He's a federal detainee, he replied. He's a patient, I corrected. Crowley watched that exchange without interruption. Caleb's heart rate spiked suddenly into the 100s and 40s. Narrow complex tachycardia, SVT, the resident said. Carotid massage is pointless, I replied. He's intubated. Blood pressure dropped again. Prepare synchronized cardioversion, I said. The pads were placed quickly. I set the joules. Clear. The shock delivered cleanly. His body jerked once against restraints. Rhythm converted back to sinus at 98 beats per minute. Blood pressure climbed slowly into the mid-80s. The room exhaled in unison. Crowley stepped closer. That was the third major event? Yes, I said. And each event increases risk of neurologic injury. Yes. So you understand why timeline matters. And you understand why movement now could kill him. He didn't argue. Caleb's eyelids opened again. You didn't walk away last time, he said to me. I finished my contract, I replied. You filed the report anyway. Yes. And they called you insubordinate. I didn't answer. Crowley's gaze sharpened slightly at that word. Caleb continued, voice faint but steady. They said unstable wasn't operationally convenient. The monitor beeped steady, indifferent to language. Don't talk about Helmand, I said. You were right, he whispered. That doesn't matter right now. It does. His heart rate climbed again with the effort. I leaned in close. You're alive because of chemistry and timing, I said quietly. Stay focused on that. He studied me through half-open eyes. You don't want them to erase it again, he said. The ICU attending shifted uncomfortably. Crowley's voice remained even. No one is erasing anything. Caleb gave a faint look that didn't reach humor. Records get edited, he said. Not here, I replied. Silence settled heavy between us. The ventilator hissed rhythmically. Pressors clicked through their programmed rates. His oxygen saturation dipped briefly to 87%, then climbed again as the ventilator compensated. If he arrests and fails to achieve return of spontaneous circulation, the ICU attending said quietly, we need to define endpoint. I looked at him directly. He gets full effort, I said. Appropriate duration. And if there's no neurologic recovery, we evaluate based on exam. Not fear, answered. Crowley adjusted his stance slightly. You're prepared to carry that responsibility, he said. Yes. Caleb's hand twitched against the restraint. I didn't swallow it to die, he said. I know, I replied. I swallowed it to choose where. That was the clearest thing he'd said all night. Crowley folded his hands behind his back. Choice has consequences, he said. Yes, Caleb answered. His blood pressure stabilized in the high 80s. Heart rate under 100. Oxygen saturation steady at 93%. For the first time in the last hour, the alarms weren't screaming. The ICU nurse looked at me. He's holding. For now, the resident added. I didn't comment. Caleb's eyes stayed open a little longer this time. You won't let them say stable, he said softly. No, I replied. His gaze relaxed and in on surrender, but in trust. The monitors continued their steady rhythm, not strong enough to relax anyone, not weak enough to panic. Crowley stepped back toward the door. "We will reassess in the morning," he said. "I reassess constantly," I answered. He nodded once and left the room. The ICU attending glanced at me. "You're carrying more than physiology here," he said. "I'm carrying a patient," I replied. Caleb's breathing evened out again under the ventilator's rhythm. His numbers held. Barely. And in that thin space between stability and collapse, I understood something clearly. If he died on my watch, it wouldn't just be a code. It would be a record rewritten by silence. I reduced his oxygen from 100% to 90 and watched to see if his saturation would hold. It dipped to 91, then steadied at 93. Acceptable. Not comfortable, but acceptable. His blood pressure stayed in the low 90s on dual pressors. Heart rate under 100. No new arrhythmias in the last 20 minutes. That counted as progress. The ICU nurse updated the chart. "Lactate trending down again," she said. "Not normal, but improving." "Good," I replied. Caleb's eyes opened slowly. Clearer now. "Sedation light enough for assessment." "Can you follow commands?" I asked. He blinked twice. "Move your right hand." His fingers flexed weakly against the restraint. Left hand. Same response. Neurologically intact for now. Crowley entered again, quieter this time, like he understood the room had rules he couldn't override. "Dr. Mercer," he said, "we need to discuss deposition logistics." "Vitals first," I said without looking at him. He waited. Caleb shifted slightly, eyes landing on Crowley. "You're worried about your clock," Caleb said faintly. "I'm worried about compliance," Crowley replied. "With what?" Caleb asked. "Federal procedure." Caleb's lips twitched around the tube. "Procedure didn't help him," he said. The ICU attending glanced at me. "Let's keep this clinical," he murmured. I leaned closer to Caleb. "You have a deposition scheduled within 72 hours, I asked. He nodded. "Sealed federal review." Crowley confirmed. "Closed proceeding." "Related to Helmand," I said. "Yes," Caleb answered. "And other transfers," I pressed. A slight nod. Crowley's posture stiffened, but he didn't interrupt. "You understand," I said to Caleb, "that your testimony requires you to be physically stable and cognitively intact." "Yes." "You also understand that if you destabilize again, you may not meet that threshold." He held my gaze. "I understand," he said. His blood pressure dipped briefly to 88 systolic. I adjusted pressors by a small increment. "You bought yourself time," I said quietly. "But not certainty." "I didn't need certainty," he replied. "I needed daylight." The phrase hung in the air. Crowley cleared his throat. "Dr. Mercer, at what point would you consider him stable for monitored transport with full critical care capability?" "When he's off pressors for at least 6 hours," I said. "When he maintains blood pressure without chemical support." "When arrhythmias cease." "When oxygenation is stable below 50% FiO2. "That could take days," Crowley said. "Or hours," I replied. "Toxicology isn't predictable." Caleb's eyes shifted back to me. "They'll say I was stable," he said. "They can't," I replied. "They did before." The ICU nurse glanced at the monitor. "He's stable right now," she said cautiously. "Stable is not the same as safe," I answered. Crowley stepped closer. "Doctor, if he reaches minimal stability and we delay beyond reasonable medical necessity, it becomes obstruction." "I'm aware," I said. "And are you prepared to justify that delay under review?" "Yes." Caleb watched that exchange carefully. "You're still doing it," he said to me. "Doing what I asked. Choosing the record over convenience." "I'm choosing the patient," I said. His eyes didn't waver. "That's why I gambled," he said. "You gambled with your own life," I replied. He gave a slight shrug against the restraints. "Better than disappearing quietly." The ICU attending looked at Crowley. "If he remains unstable, transport is not defensible," he said evenly. Crowley nodded once. Understood. He looked at Caleb. The deposition will proceed as scheduled if medically cleared, he said. Caleb didn't blink. And if I'm not cleared? Crowley held his gaze. Then the court will evaluate. Evaluate what? Caleb asked. Continuance, Crowley replied. Caleb's heart rate climbed slightly with that word. Continuance means delay, Caleb said. Yes. And delay means... Enough. I cut in. Stop. His blood pressure dipped again, not dangerously, but enough to remind us stress was not abstract. I adjusted sedation slightly upward. Focus on breathing, I said. He nodded faintly. The ICU nurse leaned close. Pressure's holding at 92. Keep trending, I said. Crowley shifted toward the door. We will need documentation copies, he said. Full chart. You'll get certified copies through legal, I replied. Understood. He paused. Dr. Mercer, he added, you realize your notes will be scrutinized. I write them that way, I said. He nodded and left the room. The colonel stepped in briefly as Crowley exited. Is he going to make it? The colonel asked. I don't know, I said. That's not reassuring. It's honest. Caleb's eyes followed the colonel. You told them stable? He said faintly. I did not, the colonel replied. Not you, Caleb said. Before. The colonel's expression hardened slightly. That review is ongoing, he said. Because I refused to edit, Caleb answered. I watched the monitor carefully. No new arrhythmias. Oxygen steady. Pressors unchanged. You refused? I asked. Yes. And that's why you're testifying, I said. Yes. The colonel looked at me. You see why he needs to appear, he said. I see why he needs to survive, I replied. Caleb's eyelids drooped as sedation deepened. You won't let them move me early, he murmured. Not while you're unstable, I said. He gave a faint nod. The monitors continued their steady rhythm, less frantic now, but still fragile. The ICU nurse checked his pupils again. Equal and reactive, she said. Good, I replied. For the first time since he'd arrived, the numbers weren't sliding backward. They weren't secure. But they weren't collapsing. Caleb's breathing synchronized with the ventilator in steady intervals. His heart rate remained under 100. Blood pressure held in the low 90s with support. The window he had forced open was still there. And as long as those numbers stayed on my side of the line, the record would reflect exactly what happened in this room. I watched the norepinephrine drip run dry and didn't replace it. For 6 straight hours, his blood pressure held above 100 systolic without chemical support. No new arrhythmias. Oxygen down to 40% on the ventilator. Lactate trending toward normal. Pupils equal and reactive. He was still intubated, still weak, but stable enough to move. I didn't rush the call. I repeated labs, rechecked electrolytes, reviewed telemetry strips myself. I'd learned a long time ago that stability can be a lie if you don't verify it twice. The ICU attending leaned over the monitor. He meets criteria. Yes, I said. You comfortable clearing him? Yes. That didn't mean I liked it. Crowley arrived within 30 minutes of the official medical clearance note entering the chart. Efficient, predictable. Status, he asked. Stable for critical care transport, I said. Intubated, ventilator dependent, but hemodynamically stable without pressors. He nodded once. Air transport is standing by. The colonel stood just behind him. Caleb's eyes opened when I leaned closer. You're moving, I said. He blinked once. Vitals are stable. You made it to that part. A faint shift at the corner of his eyes suggested relief. Deposition, he whispered. You'll get there, I said. He held my gaze. You documented everything he said. Yes, exactly. Yes. His breathing synced steadily with the ventilator. Good, he murmured. The transport team arrived with their own ventilator and monitoring equipment. Clean, professional, practiced. They transferred lines carefully, rechecked tube placement, secured restraints. I reviewed the chart one final time before signing the transfer form. Diagnosis: organophosphate poisoning resulting in cholinergic crisis and hypoxic cardiac arrest. 2 subsequent arrests in hospital. Treated with atropine pralidoxime mechanical ventilation vasopressors. Stabilized after 36 hours ICU. No ambiguity. Crowley watched as I signed. "You understand this will be reviewed," he said. "I expect it to be," I replied. The colonel stepped closer to the bed. "You're clear to proceed," he told Caleb. Caleb's eyes shifted briefly to him, then back to me. "Not done," Caleb said. "No," I agreed. "You're not." They rolled him toward the elevator, guarded but no longer frantic. Just procedural now. The hallway was quiet at that hour. Nurses glanced up from stations but didn't stare. Hospitals have a way of absorbing extraordinary events without ceremony. When the elevator doors closed, the ICU felt larger and emptier at the same time. I stood there for a moment longer than necessary. Then I went back to charting. The review started before sunrise. Hospital legal called first. "Angela, we'll need a complete statement," the attorney said. "You have the chart," I replied. "We'll need your narrative as well. You'll get it." Next came a call from the chief medical officer. "There's already federal inquiry attached to this case," he said. "I'm aware. They're asking whether transfer was delayed beyond necessity. It wasn't. Document your justification thoroughly. I already did." He paused. "You understand how this looks?" "Yes," he sighed. "Just make sure it looks correct." That part I could control. By noon, I had completed a supplemental note detailing each hemodynamic event, every arrhythmia, each pressor adjustment. Timestamps precise. Medication doses exact. No adjectives. Just facts. 2 days later, I received a subpoena. Certified mail. Request for official medical record copies and confirmation of clinical findings during detention transfer. I handed it directly to hospital legal. "You anticipated this?" the attorney asked. "Yes," he nodded. "Your documentation is solid. It better be." The internal review committee met that week. Small conference room. Neutral lighting. 3 physicians. 1 administrator. They asked measured questions. Why did you suspect organophosphate? Pinpoint pupils. Bronchorrhea, bradycardia. Collapse without trauma. Why initiate pralidoxime without confirmatory labs? Because waiting would have increased mortality risk. Why decline early transfer? Patient unstable under EMTALA stabilization standards. No raised voices, no accusations, just careful scrutiny. At the end, the chair nodded slightly. "Your decisions fall within acceptable emergency medicine practice," he said. Acceptable. That was enough. 3 weeks later, an email arrived from hospital legal. Subject line, Federal Deposition Update. I opened it alone in my office. Staff Sergeant Caleb Rourke successfully completed sealed federal testimony. No further immediate action required from attending physician. That was all it said. No details. No conclusions. Just confirmation. Later that evening, I checked the federal court docket. Restricted access, but one entry was visible. Review of archived military medical documentation reopened. No headlines. No public statements. Just a line in a system somewhere. I went back to my regular shifts. Chest pain at 2 a.m. Pediatric asthma exacerbation. Elderly fall with hip fracture. The ordinary emergencies that fill most nights. But something had shifted. Not in the hospital. In me. Years ago in Helmand, I had filed a report knowing it would be edited. I had told myself documentation was enough, that the record would protect itself. It hadn't. This time, I had the same choice in a different room. I could have cleared him early, could have deferred to federal urgency, could have labeled him stable at the first sign of improvement. No one would have questioned it loudly. But I didn't. I treated physiology, not pressure, and the record reflected that. One night about a month later, I was finishing notes when my phone buzzed. Unknown number. I let it go to voicemail. The message was short. He made it. And he's talking. No name, no signature. I deleted it after listening once. Not because I didn't care. Because I did. I locked my office, walked back through the ER, and checked the trauma bay where he had first flatlined. Different patient now. Different crisis. The monitors beeped with their usual indifference. I rested my hand briefly on the crash cart before heading out. I didn't save a soldier that night. I stabilized a patient long enough for a record to exist. And sometimes in a hospital, that's the difference between silence and something that can't be erased. I still think about that night more than I expected to. Not because of the uniforms, not because of the federal pressure, and not even because he flatlined in my ER twice. I think about it because it reminded me what the job really is. Hospitals are strange places. On the outside, they look controlled, structured, professional. On the inside, they're where law fear, ego regret, and biology collide in real time. And when everything crashes down to a single monitor line, titles stop mattering. Rank stops mattering. Politics stop mattering. What matters is whether you do your job clean. That case didn't make me proud. It didn't make me angry either. It made me careful. As doctors, we like to believe we practice medicine in a vacuum. We don't. We practice inside systems, military systems, legal systems, administrative systems, insurance systems, and sometimes those systems bend under pressure. The only thing that doesn't bend if you don't let it is documentation and decision-making rooted in physiology. The biggest lesson I took from that night wasn't about organophosphate poisoning. It wasn't about federal testimony. It wasn't even about my past in uniform. It was this: you don't get to decide who deserves oxygen. You treat the body in front of you. You chart what you see. You let the record stand on its own. That's it. There's a myth that hospital medicine is dramatic every day. It's not. Most nights are routine. But every once in a while something happens that tests whether you're still practicing medicine or whether you've started practicing convenience. That night I chose medicine. And I'd make the same call again. If you're drawn to real hospital stories, stories about doctors and nurses facing decisions that don't make the news but change lives quietly, make sure you subscribe. These are real doctors' stories and nurses' stories from inside the hospital told exactly as they happened. No exaggeration, no hero speeches, just what it feels like when the monitor goes flat and you have to decide what kind of physician you are. If you're still here, thanks for listening.